So what about the other side of the coin? How do we not undertreat patients? So here's a case, 55-year-old, node negative this time, 1.5 centimeter, moderately differentiated, strongly ER/PR positive, HER2 negative, with a low oncotype score, so no chemotherapy. So Marla, what do you think about on this case?
This one, first of all, when we look at the oncotype score, which Linda had talked about earlier, it really is not predictive for extended benefit with endocrine therapy. I would definitely, again, feel that she would be someone that I would mention breast cancer index to, because we just don't know. Yes, clinically, she looks like she's a low risk. She's node negative, 1.5 centimeters. But it's really good to include the patient, especially with joint decision making, and bring up breast cancer index tests so we'll know exactly what we need to do moving forward after 5 years.
And Mayra?
And all I have to say is that some of those benign looking tumors are in the end not so benign. And so I explained that to the patient and I said, look, this is the data that we have. Let's go forward with this test.
So I think we've all been talking for many years about personalized medicine, and this is somewhat at its finest, where you really can make treatment decisions for these patients where it is individual to them. So this patient was an 8% with benefit. So again, like Mayra said, this looks like kind of a benign breast cancer, kind of a very, very happy breast cancer. They should be good at year 5. So this is that patient that at year 8 or 9 has metastatic disease if they didn't get extended endocrine therapy. So BCI identified about 25% of patients that look good, yet really the biology wasn't quite as good as we thought, and they actually had higher risk. And maybe looking back over the years in my career, I think of patients that should have been good. You know, they were a T1BN0, strongly ER/PR positive. They were actually compliant with their therapy, and they should be good. And then here we are at year 9, and they're on first-line metastatic therapy. So don't not look at your earlier stage patients as well.